As a healthcare professional, I'm very keen to ensure that all of my patients with diabetes have a foot examination on a yearly basis. As a minimum, the foot should be inspected thoroughly. And a good place to inspect and even start, so you don't miss it, is in between the toes. In between the toes, the skin is often macerated and quite moist, and that can be a site of infection, particularly if there's breaks in the skin. Then the whole foot should be inspected for swelling, to see if there's any deformity of the foot, to see if there's any callus formation, and to see if there's areas of infection. So as a healthcare professional, it's important to differentiate between hot and cold areas. The hot areas can be due to infection, or they could also be due to the inflammatory process that you get with a neuropathic joint, such as Charcot's joint. The cold areas can be due to peripheral vascular disease, so here the arteries of the foot or the lower leg have been occluded, resulting in an ischemic foot. This foot will often be pulseless, it will be cold, it will be painful, and will also be numb. We should then move on to an inspection of the pulses, and the pulses that we inspect are at the ankle joint but also on the foot itself, and the pulses are called the posterior tibial pulse and the dorsalis pedis pulse. We should then move on to an examination to see if there is any numbness, and normally we would use a 10-gram monofilament. We could also use a tuning fork, and if you don't have those pieces of equipment available, you can just touch the toes, and that can be equally effective. You must also check the capillary return. The capillary return is simply pressing the toe and seeing that it blanches, then letting go, and it should fill up red again. And that should happen within 2 to 3 seconds. It's critically important to look for signs of infection. So even small breaks in the skin or small areas of cellulitis can become quite large areas of cellulitis over the next few hours or days. So please do look out for infection, and they can be treated aggressively at the onset, initially with oral antibiotics, but in many cases intravenous antibiotics may be needed.
During the annual foot check, it's also important to ask the patient if they've ever previously had any concerns with their feet, any previous foot ulcers, any problems where they may have been seen by the diabetic foot screening department, or any general concerns that they have about their feet or their previous history.
Once you've conducted the patient's annual foot check, it's very important to make sure that the patient understands that they should check their foot on a daily basis. They should inspect their foot, they should look in between the toes, they should look at the bottom of their foot, and particularly look out for areas of redness, callus formation, any swelling or any deformity or any numbness or any places where it's particularly cold. So in terms of preventing foot problems, it is a good idea to stress aspects of advice and then move on to cardiac risk factors. So aspects of advice would be particularly not smoking, maintaining a good level of physical activity, and optimal weight. Blood pressure is going to be important, as is the management of the cholesterol. If you manage the blood pressure and the cholesterol, you're less likely to get blockages in the blood vessels and less likely to get peripheral vascular disease. Diabetes control, if that's good, will lead to less peripheral neuropathy and numbness in the foot, and also will reduce the chance of atheromatous disease happening in the foot. Sometimes aspirin is important as an antiplatelet or blood thinning agent to help the circulation, but please make sure that these can be given safely to your patient.
There are 3 risk levels when assessing a diabetic foot. Low is when there is no problems or concerns at all. The circulation is within normal limits. They are able to feel the foot is in good condition. That should be repeated once a year. If they have got a loss of sensation or any slight deformity that may be considered a moderate risk, they may need further assessment by a specialist diabetic podiatrist and further written advice and seen more frequently dependent on the severity of their condition. If there's a high risk, usually indicates there is a loss of sensation, a loss of pulse, an active foot ulcer, or deformity of the foot that needs immediate attention and should be referred straight away to the diabetic foot team.
If a patient is diagnosed with an active foot problem, then we have to think about what is this. If it's an infection, then intravenous antibiotics or, in early cases, oral antibiotics may be enough. Sometimes the active foot problem will be an inflammatory neuropathic joint. By this I mean a Charcot joint. That requires very specialized management. Often the joint needs to be encased and often needs to be offloaded as well, and certain drugs may actually help. But the Charcot joint has to be managed by a team that specializes in neuropathic joints. If the foot is cold, then we have to suspect that this is peripheral vascular disease, and the potential for blockage of a blood vessel in the foot or the lower leg is very high, in which case an assessment by a vascular team is needed, so we can think about angioplasty and possibly bypass surgery as well.